everybody. Welcome once again to the Big Ideas Theater. I'm your host, Ed Hyland, and I'm joined now by RT, Thomas Perreno, who is talking about prone positioning being used in moderate ARDS. You've been kind of talking on the pro side of the debate, and so let's talk a little bit about this as a debate issue, if you will. Why is something in moderate ARDS for the prone position something to be considered?
Well, the previous knowledge of what we understand with prone positioning is that there was no benefit to prone patients in any category of ARDS. So the earlier studies showed no benefit. They used different categories of ARDS from mild, moderate to severe. Now they all did this prior to having an actual definition of what severe and moderate ARDS was. They were all grouped in the same category, and then we had acute lung injury, which is now called mild ARDS. Now the most recent study, the ProSEVA study, the title was Prone Positioning in Severe ARDS. So when they started the study, we didn't have a definition for what severe was. So they used a cutoff of a PF ratio of less than 150 millimeters of mercury. Now that we have a definition which came out just before this study was published, the now classification for moderate is between 100 and 200. So you can see there's a subgroup of patients between 100 and 150 millimeters of mercury that were actually included in this study. And the ProSEVA study provided a breakdown in quartiles of PF ratio, and when you actually look at that evidence, it's in the supplemental data, so most RTs and clinicians reading the paper won't see this, but the benefit for the subgroup of patients with moderate ARDS by our current definition actually had a better response and had a larger difference in mortality compared to the supine group. So again, people thinking severe, they don't think that this category of patient was included in the study, but it was because of the lack of definition. So the study evidence is there, plus there's been meta-analyses that have looked at all of the proning studies and taken into consideration different things that are important and found that yes, indeed, patients with PF ratios less than 200, which is moderate to severe, all benefit from prone positioning.
Now, are there other therapies that should be considered prior to prone positioning?
Absolutely. So in those meta-analyses, they discuss a number of issues that they weren't commonly addressed in previous studies. One is lung protective ventilation. So the use of 6 mils per kilo of predicted body weight, tidal volume, and low plateau pressures. Also using longer durations of prone positioning. And probably most important, we think has a pretty significant synergistic effect with prone positioning is the use of neuromuscular blocking agents for a short period of time during the course of early ARDS, because there was another study that showed benefit to doing this in the same group of patients, 150 millimeters of mercury or less. So the ProSEVA study used a lot of neuromuscular blocking agents in the prone position patients, and we think that it's basically significant impact on their outcomes. But all these things need to be considered. So you can't just take a patient that meets criteria and prone them and expect to get the same results as ProSEVA. They were very specific at basically addressing every previous issue that the previous studies had that they did wrong. Whether it was how long they prone people, so more than 10 hours is recommended, ProSEVA did 16. Earlier studies did 8 or 7 hours of proning. So clearly they basically hit every previous issue and said we're going to design the most perfect protocol we can, and then we're going to use this protocol, and they had a 50% reduction in mortality compared to supine patients, so very drastic.
Are there other areas of risk that should be discussed here?
Yeah, so this is a constant thing that gets brought up because people think the reason why they don't prone enough, and interestingly enough, although we have the data, I don't say it has evolved, it's more like it's mutated, because the evidence was kind of continually saying that it was no benefit, all of a sudden a 50% reduction. So people tend to say it evolved over time, but really it mutated with the ProSEVA study because they hit every single factor. But the same authors that did ProSEVA published a previous study years ago, in 2004 was published in the same journal, New England Journal of Medicine, and they actually found no difference in mortality, but they had significantly higher adverse events, such as pressure sores, kinking of tubes, and main stem intubation. And what's interesting is the same group of people now years later performed a study with a much more strict protocol, focusing on turning the head every 2 hours. All of a sudden the complications that were there in previous studies are no different between the two groups. So they've actually lowered their complication rates. Now, however, this means that these centers had years of experience. So this has been my biggest argument actually for proning in moderate ARDS is that are you going to get experience proning your patients when you wait too long that they're so sick that now it's a huge risk to possibly do this, or do it earlier when they have moderate ARDS? We have data now that it's actually beneficial in that subgroup of patients, and you're probably less scared to do it, so you're going to gain the experience to make sure the adverse events are minimal.
You use the term evolving, and I'll use that one also because, as we were discussing earlier, this is relatively new as far as the data goes, and it is something that is not as widely utilized as perhaps it could be.
Yeah, absolutely. So there's a study called, the general way of doing it, calling it is the lung safe study by Dr. Balani and colleagues, and it published sort of the epidemiology of how we manage ARDS across, so globally. So they looked at over 450 ICUs in 50 different countries and 5 continents, and they looked at the use of prone positioning and a number of other ventilation adjunctive therapies, and prone positioning was extremely low. So in the severe ARDS group, so less than 100, it was around 16% of patients were actually prone. And in the moderate group, it was closer to 5%. So there's a lot of work that needs to be done globally in understanding that if you're scared of prone, so this is one of the reasons why they think it's so low. People are hesitant, they think it's dangerous, and it's inconvenient. But I can tell you from experience working in a hospital that prones patients regularly, the inconvenience and the fear of the safety adverse events occurring, it starts to go away very quickly when you get experience doing it.
Prone positioning for moderate ARDS. Thomas Perino, thank you so much for joining us.
Thank you for having me.
I'll get it right.
Yeah,
thank you so much. And this is the Big Ideas Theater. I'm Ed Highland. It's sponsored by Draeger.